Start.
Okay, so Valeria, thank you very much for the invitation. It's a great pleasure to be with you today to share my experience on treating patients that need multidisciplinary approach, especially treating those patients with Invisalign. So multidisciplinary, it's a word that has a lot of meanings, but today I will share you tips and tricks that I use every day in my daily practice. And at the end, we're going to come up with conclusions and we'll answer questions about retention, where is the limit. We're going to discuss about excellence in orthodontics as well. Before that, I would like to introduce myself. This year, I'm the president of the meeting in Limassol, Cyprus. The meeting will be the 30th of June until the 30th of May until the 3rd of June. I studied dentistry at the University of Tennessee at Memphis. And I had the honor to have Jim Vaden and Walter Sandusky as two of my professors and teachers there. They're both very strong in tweet. So my background as an orthodontist is treating patients with all the tweet philosophy. And I was very proud at that time to use my Steiner and Kuhn pliers, my closing loops, and all those 0-0 torque appliances and the philosophy behind tweet. And I do remember Jim was always used to tell us that we have to stick to the basics. And this is something that we were doing in Memphis. But I do believe strongly that no matter of the appliance that you use, it depends on you how to treat your patients. So if you give me a bracket, I will make your teeth straight. However, we know that there are some advantages on different bracket system. Also, I do see a lot of advantages when I treat my patients with Invisalign as well. I'm a member of the Angle Society of Europe. I'm honored to be a member of the Angle Society of Europe that has about 55 active members, some of the most known orthodontists in Europe. And we do have a meeting in Austria once a year for a week. And during this meeting, we share a lot of information. We have a lot of fights about new things that we introduce to our specialty. And I'm also a very good friend with Bjorn Ludwig, that he's treating a lot of patients with mini screws and distalizing his molars with screws that he puts on the palate. But my philosophy is close to a philosophy of another good friend from the Angle Society, Lawrence Moser, that he's talking about the keep it simple and keep it straight, which is the KISS principle that was introduced by Wig Alexander, that unfortunately he passed away last week. Wig was one of my professors in Dallas, Texas, when I was there. I have a very busy practice in Limassol. We do see about 100 patients every day, which is quite a lot. And I'm also the director of the Cyprus Center for Clefts and Facial Deformities. That's called MediCleft. So I do treat a lot of infants, a lot of kids that are born with clefts and other craniofacial anomalies. And this is one of the things that I love to do the most. I'm a president. It's called Limassol Volleyball, where my two daughters are playing. So I'm also very happy to be part of this excellent team. I'm an examiner of the European Board of Orthodontists. And as I told you, I'm the president of the EOS, of the European Orthodontic Society. I'm also teaching at the European University of Cyprus. And I want to give credit to this guy here, who is Panos Peros. He's the guy who introduced me to Invisalign. And I owe him a lot because Invisalign came to my life. and change a lot the way I see my patients and the way I treatment plan my cases. We all want to finish our cases into an excellent occlusion, but we should never forget the aesthetics of the smile and the aesthetics of the face. So when we treat our patients, we should pay attention, of course, to the occlusion, but also on the face. And we should all grow through our specialty, through our practice, and we have to develop a growth mindset. We should adapt and learn rather than expecting to have all the answers right now. And what I mean by that is that many people, they hear about Invisalign and they are scared to jump into the new system because they don't know all the tricks, they don't know all the basics behind it. But you do have to have the power of growth in order to incorporate new techniques and new technologies in your practice. And I use Invisalign, and the way I'm selling Invisalign to my patients is because there is essence behind this technique. And what I mean by essence is that with Invisalign, I have less emergencies. So E stands for emergencies. I have shorter appointments. So when the patients come to my practice, they don't stay in the practice for long. So shorter appointments. So there's a great benefit for my practice and for the growth of my practice. It's a safer technique. We don't have any wires poking. We don't have brackets that get loose. Patients can eat what they want. So E stands for eat what you want. There's no plaque, no pain, and we create new smiles with this technique. It's more comfortable for everybody, and there's no question for that. And last but not least, it's more aesthetic. So essence in Invisalign, and that's why we use it. So two disciplinary cases. I will talk about cases that needed composite buildups. I will share with you a case that I treated with a laser treatment. I show you cases that I prepare for implant placement and then the prosthetic work, perio ortho patients, orthoprosto, and then orthognathic surgery patients. And with this, I'm going to the first presentation, the first patient. This is Georgia. She's a class 1 patient with mandibular retrognathis, and she also has bimaxillary protrusion. The chief complaint when she came to see us was that she didn't like her smile. She was really unhappy about her face, about the aesthetics of her smile, and about her bite. She had a slight asymmetry. She had a flat smile line. She had a gummy smile mainly on the upper left side. The profile was convex. She had mandibular retrusion with a prominent nose and a short upper lip. Those are the photos of Georgia with the mouth closed. You see that the mentalis muscle was strained, and you can see the gummy smile, especially on the left side. The convexity of the face. You can even see from the profile photos that she's unhappy. And looking at the bite, she had a slight open bite on the right side, a small diastema between the centrals. In Georgia, she had previous orthodontic treatment that lasted for 3 years. So the orthodontist who treated Georgia was able to finish her in a class 1. You see that molars are in class 1. However, he tried very hard to accommodate all the teeth in the mouth. So the pressure of the tongue was pushing everything out. That's why we have the open bite. That's why we have the anesthetic outcome of the smile and the face. So this is a patient, this is a case that we could discuss a lot about the importance of having good occlusion, good class 1, with excellent interdigitation, but we should never, never leave the face having a bad outcome, a bad look. The retainers after the orthodontic treatment that she had. So here the question was whether we could treat Georgia just with orthodontics, would need orthognathic surgery. So we discussed it a lot. We're debating what was the best for her, and we decided that we should start treating her by having extractions of the first bicuspids. All the cases that I would show to you today were treated with Invisalign. You can treat them, of course, with any other system, but that was my choice of preference. So here I'm drawing some lines so you understand the gummy smile on the left side. You see the asymmetry. The reverse smile line. The profile view. And the panoramic X-ray. You see the impacted wisdom teeth. So on this case, probably the orthodontist should have taken out the teeth on the first orthodontic treatment. So he would be able to accommodate the wisdom teeth in place. And on the lateral ceph, you see the inclination of the upper and the lower incisors, which is contributing to the anesthetic aesthetics of the smile and the face. I always like to draw these two lines. The one on the right, it's a line drawn perpendicular from A and S. And when I have this line straight down, I want my upper incisors to be tangent to this line. And the second line, the one on the left, it's a line drawn from Pogonion straight up, perpendicular to the Frankfurt. And on this line, I would like my lower incisors to be on that line. So here, imagine that the lower incisors are way forward and also the chin is way back. This is why we decided to extract 4 bicuspids, but that was a case that we thought maybe she needed also surgery. These are patients. We removed the retainers. Georgia was studying in London, so she would fly back and forth from Cyprus to London. It's a 5-hour flight. I would see her once every 3 months. That's what we discussed in the beginning. So we extracted the first bicuspids, and that was the first clean check, the final clean check that I had. The way I'm doing my clean check, other lectures today about attachments and clean checks, but I like to have, if I would do this today, on the cuspids and also on the second bicuspids and even on the molars, I would like to have bigger attachments. Those are the optimized attachments that the company is placing for us, but I would change them to place my own vertical 5mm attachments in order to have better control for the movement and the closure of the spaces, because I want to have control of the root parallelism when I close my spaces. Another thing that's important with a clean check is that we have excellent indication of the spaces. For example, here we have a Bolton discrepancy. We have small lateral incisors. And this is a very good communication tool that I would send to the general dentist, and I would discuss the veneers or the composite buildups after the finishing of this case. And if I get the approval, I also communicate this with the patient in order to have approval of my patients as well. I'm checking a lot the interdigitation, the occlusion, the class 1 occlusion, and also very important is overlapping of my upper incisors with the lower incisors, and the inclination of the anterior of the upper and lower incisors as well. So this is my patient when we started closing the spaces. Many people ask me whether I'm using any auxiliaries when I have extraction cases with Invisalign. And the answer, it depends on the case. Sometimes when you have small molars, for example, here, the molar you see, it already started to have an inclination to the mesial. This is an indication that I may need some auxiliaries. I use power arms, and I also use some regular clear braces on the posterior segments with tats in order to be able to mesialize the molars and the bicuspids. I'm showing you the progress of the case. So here the spaces are closing even better, but I do not like the inclination of tooth number 46. 36 is slightly better. So here, I know that I'm going to use some auxiliaries to upright this tooth. I'm not expecting that the plastic of the Invisalign is going to be able to upright this tooth. And with the size of my molars. So I'm closing the spaces and I'm leaving a little bit of space as I showed you on the clean check in order to build up with the dentist. And here's my patient at the end of treatment. You can see a big change on the profile, excellent aesthetics from the 3/4 views. So here the only thing that I actually did was to trim and plant this case better. I left the space to build my laterals, and I worked with some braces on the posterior segments to upright my molars. But I was able to achieve very good occlusion, center my midlines, have better symmetry of my smile aesthetics, which is very important. Excellent exposure of the upper incisors. This is something we have to take a lot of attention. So those little details are very important when we treat our patients. Very good inclination of my upper incisors because we want good supports for the upper lip. And here you can see that the face before treatment and after treatment has changed tremendously. And also the smile of our patient has changed a lot. On the profile view, we definitely see a profile that now looks orthodontic by just removing 4 incisors. And this is what needed to be done from the initial treatment. So unfortunately, our patient had to go in 3 years of treatment and then redo the treatment with extractions. So my advice here is that if you feel that your patients need extractions, do not hesitate to do it. If you feel your patients need orthodontic surgery, do not hesitate to advise them for orthodontic surgery. Because if you try to be a hero, if you try to keep your patients in your practice just by offering them a treatment that sounds very good in their ears, I think this is not good for them. So this is our final profile, and this is how we started. So you can see a big change only by extracting teeth and using a system that was very easy. Remember the word essence, because there's essence in using Invisalign. A system that was aesthetic, a system that was comfortable, a system that allowed our patient to eat what they wanted with very good oral hygiene. But one of the most away, so she would fly in Cyprus every 3 to 4 months to see me, and we were able to finish a treatment long distance. There's not easy way to do it with traditional braces. So Invisalign is giving us a way to work long distance with our patients. And the smiling profile, you can see a great change on the profile. And the three-quarter views, the occlusion, the lateral segments, the left occlusion. You can see how we changed the shape of the arch and the lower arch as well. Now, many people ask me about the retainers I use. I like to use fixed retainers from cuspid to cuspid on all my patients. We do sandblast before we place them with also traditional etching technique. And in addition to the fixed retainers, we give them retainers to wear at nights, that they wear them every night for a year, and then we ask them to wear retainers once a week. This is my retainer protocol. I found that it works well, but of course you need patients that they're very good in cooperating with you, brushing their teeth very well, and doing following the instructions according to what you tell them. This is the smile aesthetics. You see a big change on the smile line. We started with a reverse smile line, and we ended up with a very nice smile with teeth that were following the lower lip. And big change on the profile. So to conclude on this first patient, I would say that we have to focus on occlusion and also the face. We have to plan our treatment, so spend time on planning, and do not hesitate to ask for extractions, do not hesitate to ask for orthodontic surgery. And many people ask me, is Invisalign treating complex cases? I don't think that Invisalign has any cases that cannot treat. However, we know that medializing posterior teeth, it's not an easy task. So many times we need either braces, we need TADs, we need other ways to be able to do it, because it's not easy for the plastic to grab a molar, a third molar or a second molar, and move it forward. So you have to be prepared to use auxiliaries with this technique, especially on medialization of posterior teeth. So I hope everything is clear for this first patient. And I would like to move to our second patient. This is Panayotis. It's a class 1 crowding patient that he already to work around the implant, around the already prosthetic work she had. And then we had to design a new prosthetic work on tooth number 11, where we had the implant. This is our patient with a nice profile. It's rather concave, but very nice profile. He didn't like the crooked teeth he had. He had a slight facial asymmetry. You can see that on the smile. His face was concave, slightly maxillary retrusive with a prominent nose and a long face. So this is the occlusion of our patient. So based on the concavity he had on the face, we decided that we didn't want to extract any teeth, even though the crowding was a lot. Another tip that I would like to give you, especially the young orthodontists in the audience, is that we have a lot of crowding on the lower, and many times when we have a deep curvoscopy, I like to take photographs with the mouth slightly open. This is a very good way to identify your crowding, to identify any gum recessions that you may have, to identify any wear of teeth. So taking this photograph, the one I'm showing here, it's an excellent tool for your diagnosis and treatment planning. So it's a class 1 patient. I would say it's not very easy because tooth number 11, it's an implant. And he also has a lot of crowding that we had to solve without extracting any teeth. So we started treating Panagiotis, and we had to work around the implant. The first set of aligners were 37. You see, we're doing a lot of expansion. We're correcting the rotations. He also has some small laterals. So here I also thought whether I would need to build them up, but I decided to maintain them. I did a lot of IPR on the lower. Maybe if I would treat him again, I would do less of IPR. So if you see him from the side, we're expanding. We're getting the anterior teeth in ideal inclinations. But here you have to understand that tooth number 11 stays behind. It doesn't move. And we work everything around the tooth. So we consult with his general dentist that after orthodontics, he's going to new tooth number 11. Maybe on this side, you can see it better. So you see tooth number 11 that maintains its position, and then we move the rest of the teeth around it. So we're starting expanding. We're doing the IPR. Slowly, we're getting everything leveled on the upper. And here's our patient when we finished. So I was able to expand. I was able to get all the teeth in place. Here you see the difference in the torque, the 11 with an implant that stayed there, and then we had to make a new prosthetic work. So this is our patient after we finalized the case completely with a new prosthetic work. The bite was good. It remained very good. This is our new prosthetic work. The aesthetics of the soft tissue maybe could have been done better here, but I think our patient is happy, and I'm also happy for the result that I gave this patient. So as a treatment here, it's important to understand the limits, work around the implant. It's important to understand why we decided to treat him without extractions, because the face was already concave. And I would say it was an easy case, but it was a case that we had to think and discuss with the general dentist about the possibility of the placement of the new crown and whether he would be able to do it after we would change the torque of the adjacent teeth. So communication is the key for success on those cases. When we have multidisciplinary cases, we really have to discuss them with our general dentist, with the patient, in order to come to the ideal result at the end. Now, checking the before and after, you see how nicely we changed the shape with Invisalign, the shape of the upper arch. The smile now is wider. We have a patient that looks happier with a new smile. The profile remained, I would say, a change. We didn't change his profile at all. But we did change the exposure of the upper teeth. You can see where we started and where we were able to correct the constriction of the arches, the crowding, and working everything around the implant. The general dentist was able to place a new prosthetic that looked much better at the end. So we had a class 1 occlusion that remained class 1 on both sides. Here you can see a very nice widening of the arch. This is a dental-alveolar expansion, which is good, which is stable. We also give our patients to wear the retainers at night. But if you do have a very good occlusion and the patients are very good with the retention protocols, then you are very successful in maintaining the results. And on the lower, with a lot of crowding, we're able to give a nice arch. You see how constricted the arch was mainly on the right side, and how nicely we're able to expand. The aesthetics of the smile, the exposure of the upper incisors. But here it's a nice photo that shows how nicely we pay attention on the details of the exposure of the upper incisors. We want incisors to have a very nice of the. This is what we like to do in all of our patients. The panoramic before and after. That was a case that needed a lot of thinking, a lot of preparation, and also a lot of discussion with the dentist and the patient in order that all of us had the same goal in our mind. And this is how we were able to maintain a very good inclination of the anterior incisors. So people ask me, is Invisalign for every case? Or are there cases that you don't treat with Invisalign? The way that I have my experience now with Invisalign is that I can use it for every case. Of course, I do use some of my cases with braces. My practice is half Invisalign and half braces. I do believe that some people still want them for several reasons, especially young kids, they may like to have braces. But in the majority of my adults, I do have Invisalign. The only limits you have are the limits you believe. So those of you who are reluctant to change to a new technique, to change to digital orthodontics, I think you should do it because the limits, I think it's the sky. You can do whatever you want. You just have to incorporate it in your practice, try new things, and by trying new things, you will be successful because every day you're learning the technique, you're mastering the technique, and this is giving you endless possibilities. Now, the third case I want to share with you, it's a case, I'm showing you not very difficult cases. I have the difficult cases for a little bit later, or maybe we can switch to the surgical cases after this one, just to go back and forth. But this is a case that I would say was an easy case. She had pec laterals, so I had to do some laser for the gingiva to give her a better gingival contouring on the centrals and the laterals, and then I had to build up the laterals. So she came to us because she heard about Invisalign. She heard that we're the best providers in Cyprus for this technique, so she wanted to come and get Invisalign. Always on the clinical examination, I pay attention on details, and this is the time that I take photos. And during my first consultation, which is the first day that the patients come to my practice, I spend a lot of time showing them details on their teeth, on their face, on their smile, that I want to change or that I would recommend to make changes. And I let them decide what they want. So I give them options and they make the decisions. So centrals, but you see that the two centrals, they have uneven gingival smile lines, gingival lines. We have attrition on the lower incisors, and we have two centrals that they are also small in size on the lower. So she's a class 2 division 2, even though she's class 1 on the posterior, but you see that she has a little bit of overlapping of my laterals, with some crowding on the lower, constriction of upper and lower as well. I'm always checking the exposure of my upper incisors, the inclination of the anterior teeth, and the panoramic to see any pathology or any problems. We're always discussing about the possibility of removing wisdom teeth if they have to. I'm not a big fan of removing wisdom teeth, but if they have to, then we discuss it. And that was one of the first clean checks showing you that we've done a lot of expansion. But on this clean check, we decided that we want to leave some space to build up the laterals. We didn't like the laterals to be small. You see how the arches are nicely expanded. So here, you see a lot of expansion. You don't see any attachments on the posterior molars. Nowadays, I almost always place attachments on my molars because I want to make sure that the plastic is holding well all the teeth. I don't want to have misfits and lose time posteriorly. So this is our patient. Try to level and leave some space on my laterals. And then after leaving the space, you see that my centrals, the gingival line is not good. So we discussed also with the patient the possibility of having some laser treatment. I use a diode laser, and I use it a lot in my practice. It helps me in many occasions. It's very efficient, it's very fast. I don't need long appointments to use it, but in a case like this, I believe that it's much better if I control the shape of the gingiva and also the height. Definitely, you can refer these patients to a periodontist, but working with your laser, a diode laser, it makes your life much easier. So we got a very good leveling on the lower, and then we decided, as I told you, for the type laser I'm using, it's a Picasso. It's a laser that I think is manufactured in China, but we also got this one from United States. Now, here is just an example of another patient, how I'm using the laser. This is a small video. I'm always using the suction because you get the smoke and the smell if you don't use it, the high volume suction. And see how easy it is. And you have to be careful not to go under a certain line, of course, on the cement to enamel junction. You don't want to have exposure of the roots. And you have to make sure that you know the aesthetics and the shape of the centrals compared to the laterals, whereas the zenith of the laterals, which is a little bit to the distal compared to the centrals. So those little things that are very important. And of course, the height of the centrals is a little bit higher from laterals. It's probably the same height of your canines. So those of you who don't have a diode laser, I would highly recommend to get one in your practice. So the black tissue you see there, we take a wet cotton roll after we finish and we take it out. We recommend our patients to rinse their mouth with salty water for 2-3 days. And if they need, they can take some painkillers. The majority of our patients, they don't need to take anything. So working on the shape, I think it takes a little bit of artistic work that we need to do, but we're very familiar with the anatomy of the gingival margins of the anterior teeth. And there's nothing that worries me at the moment. Initially, I was a little bit afraid if I would damage something using the laser, but after you use it, after a while, then you realize that it's a very easy, one of the easiest tools and instruments to use in the dental practice. You just need the suction. And this is the Picasso light I was using. Now I'm using a little bit stronger of a laser, because sometimes the soft tissues, it could be more hard to cut. So I could use it up to 3.5 watts. The one I'm using here is 2.5. But in a case like this, you see how easily and how fast it's cutting. And the nice thing also is that you don't have any blood when you do that. So this is after the gingivectomy for our patients. And here was after we created the spaces we wanted. We did the preparation for the build-ups. And this is our patient at the end of treatment. With the laser, you see now that the gingival margins are definitely much better. The laterals with the composite build-ups. Many times we're doing the build-ups in our practice, but we also refer them to the general dentist to do it. We could do some kind of intermediate build-ups in order to have excellent control of our occlusion and also the shape of the upper teeth when we finalize the occlusion. The inclination of the anterior teeth and the anterior aesthetics is very important for us. And our patient with a new smile, the wider smile. The different size of the laterals, it makes a big difference. And also what makes a big difference is the difference on the shape of the two centrals. The gingivectomy that we created made a big difference, as you can see here. Also, the expansion was very good for our patient. The occlusion was excellent on both sides. So everything is settling down nicely. And people ask me whether I have problems with Invisalign, whether the teeth are settling down. But here, if now we have occlusion. The problems that we can face is when we have heavy contacts anteriorly. But this is a different story. If you're not able to manage your occlusion, if you have skeletal problems and you try to compensate and then the teeth are heavily anteriorly, this is a different story in order not to have excellent interdigitation posteriorly. But on a case like this, everything comes down nicely. You can see the difference on the arch shape. Again, the retainers, fixed retainers, upper and lower from cuspid to cuspid, and also retainers that our patients wear at night when they sleep for 1 year. After the first year, they wear the retainers only once a week, and slowly they discontinue it. But if they keep the retainers to wear them twice a month, I would say, then everything looks much better. So the canines was pretty much the same, but we did some expansion on the bicuspid area, as you can see, and also we expanded on the molar areas. On the lower, you see the arch that changed tremendously on all the areas. So you see how the cuspids changed, the bicuspid area, and also the molar area. So we have a totally new occlusion, totally new aesthetics. So this is what we call multidisciplinary. We're building teeth, we're using our laser. So perio, we're doing restorative, and we're also doing orthodontics. So this is a multidisciplinary approach for our patients. So we have to pay attention on the details. There is no way to finish a patient with the gum showing a big difference, like you see here. And the inclination of the anterior teeth, which is important for the support of the lip and the aesthetics of the smile. And one of my advices also today is that when you plan your cases, you have to spend time with the clean check. The clean check is very important. It's an excellent tool that shows you how you would move your teeth around. And you have to spend time in order to finalize your cases in excellent occlusion and excellent aesthetics for the smile and also for the face. Now, this is Alessia. This is a patient that she's class 2 division 1. She was missing tooth 22, and she had a peg lateral on tooth 12. She came to us because she didn't like her smile. She had a facial profile with a little bit prominent nose, I would say, when I see the profile. This is our profile, the 3/4 views. We do take a lot of records because this is, first of all, it's a great way to show our patients. It's a great way to communicate and sell our cases to them. And on the other hand, we communicate with our referring dentist, and we use them, of course, for the presentation. So taking records is so important, I think, to have a successful practice. Now, you see here that we had the missing lateral, tooth 22, with a peg lateral, tooth number 12. Class 2, division 1 on both sides. The upper midline was shifted to the left. And this is one of the photos that I love to take because it shows me a lot of details. When you have a case like this, I could ask you, what would you do on a case like this? How would you treat her? Would you rather extract something on the upper right side? Would you try to treat her the way it is and maybe make the canine to look like lateral? Would you open a space for an implant? So we have several options here. But what I decided to do was to open a space for the implant on the lateral and try to distalize everything on both sides in order to create a good class 1 occlusion on my molars and the cuspids as well. I didn't show you any clean checks today. So, but I'm coming here. So we do have a lot of attachments. One of the mistakes that I did when I treatment plan on my clean check this case, I didn't place any attachments on my centrals. Here on tooth number 22, I was opening the space for the implant. So try to open that space with a lot of pressure on those teeth. There's no way to maintain a very good inclination. So I had to use some attachments on my centrals as well. Now on the right side, I'm using class 2 elastics for sequential distalization to get my molars and my cuspids into a class 1. And I'm using the same on the upper left side. You see the problem that I created here because I didn't place any attachments. You see tooth number 21 is tilting, so the root is getting into the implant site, which is not very good. And on the right side, I'm distalizing my molars. So here nicely, everything's the class 7. I usually use them on 6s, but here tooth number 46 had a porcelain, was an implant. So I didn't want to bond anything on it because we know that the bonding failures rates are higher on those teeth. So continuing, as you see here, with the class 2 elastics, the choice of attachments. This is another lecture. We can discuss about clean checks and attachments. But always when I like to sequentially distalize, I like to have attachments always on the cuspids and the laterals, because we're pulling the elastics from here to the 6s. Here I told you why I prefer the 7, because 6 is porcelain. And I use medium size of elastics. I don't use heavy. I don't use very light. So medium size, 4 ounces of elastics, 1/4 inch. This is what I like to use. So this is our patient, the progress of treatment. Again, here without any attachments, and tooth number 21 is, we're losing control of that. On the right side, we're getting very nicely into a class 1. The same on the left side. And then we decide to rescan and make some new aligners with attachments on both incisors in order to have very good control of the tip. So those 2 attachments that we're using here are controlling the tip of the incisor, mainly to get the root out of the implant place. Again, you see the different kind of attachments that I use to control the tip, and how we're sequentially distalizing. And always remember that when you run elastics from the cuspids, you always need some elastics on the laterals. So this is our patient during the preparation. It's important to develop the, we're getting bites, excellent implant site development. Here we're leaving some space for the peg lateral to have some veneer at the end. So this is a multidisciplinary case. This is a case that orthodontist has to work with general dentist, prosthodontist, and implantologist in order to be able to have excellent result at the end. And of course, patients should know the limits, should know the vision, the goal of this treatment. And keeping the teeth parallel, it's so important when we're treating those cases. Now, when we place the implant, we had to wait for the gingiva to grow nicely around the prosthetic work. So we had to wait. We place our retainers on the lower. On the upper, we had the removable retainer. This is our patient with very good oral hygiene. The gums look better. We still didn't get the final prosthetic work. She had some whitening, which is very important to finalize the color of the laterals, on both laterals. The exposure of the upper incisors, which is excellent, below the lip, the implant here, and our patient feeling happier with some teeth in place. Very nice whitening, very nice occlusion on both sides, excellent arch coordination. For example, here you see tooth number 46, the implant was slightly to the lingual. So we work around it, and we're expanding a little bit the rest, but this tooth was slightly inwards. Exposure, the smile aesthetics, and we're having a happy patient. It's a treatment that took us 2 years. It was a long treatment, but I think it's worth. We created a lot of space for the lateral. we're able to get everything to class 1. I have done some mistakes not using the adequate attachments on the central that was adjacent to the implant site. But after we place the adequate attachments, we're able to get the root parallels and the aesthetics of the incisors into the ideal position. So we're able to get the midlines on, excellent aesthetics, the smile, and some close-up photos for our implant sites, which looked actually very good. How nicely the gingiva grew around the prosthetic work. And we do have a happy patient that likes to take a lot of photos. We also take lots of photos for our patients. We have a professional studio in our office that we use it also for advertising, for Instagram, which it really helps to attract a lot of patients in the practice. It's important to use technology. It's important to work with other dentists and other specialties. But when you have cases like this, you definitely have to show it. It's important to show to the public that you're a dentist, you're an orthodontist that is striving for excellence. The close-up photos, I think they really show the story very well, especially of the implant site development and how nicely we have the gingiva growing around the prosthetic work. And this is our patient feeling happy and smiling for us. So, Valeria, now I think we've been for about an hour in the presentation. I will try to share my screen to get the presentation now with the more difficult cases. Let me stop share this and make a new share. No, this is the old one. Valeria, can you see my slides now? Okay, do you see now the screws? Is that what you see?
Yes, we can see everything. Thank you.
Okay, so you see the plates with Sugawara here on the left. Okay, excellent. All right, so I'm using a lot of those plates when I want to move teeth posteriorly. On the upper, we place it here under the zygomatic arch, and I run elastics most of the times from the cuspids or from hooks on the upper arch in order to distalize teeth or intrude my posterior teeth. And on the lower, we use these T-shaped plates for intrusion of the posterior segments when I have open bites, and also for distalization of the anterior segments. the way we place on the zygomatic arch here. We place the plates under local anesthetic in the office of the maxillofacial surgeon that I work with. It's Dr. Zoe Nicolaou in Limassol. And I always like to be present because I want to decide the position of the placement of those plates, the height, and also the anterior posterior position, because I'm going to be the one to run the elastics. So I know exactly where I want them to be placed. So there are 3 screws that are placed on those plates. And it takes 3 days for the area to heal well and then start using our elastics. You see, we can adjust also the position, the in and out of those plates. And the nice thing that I like about them is that they have 3 hooks, and you can adjust the force that you want to run on your either Invisalign or even in traditional braces. Now, the success rates of the plates is much higher than the mini screws, and they have almost 97% success rates. Now, Marie Cornelis and your team, they wrote papers about the use of those plates and the perception of patients. The most frequent problems that patients had was post-surgical swelling lasting for by more than a third of their patients, but it lessened over time. Sugavor and his colleagues, they published a paper. They found that you can intrude about 2.3 millimeters on average on the posterior teeth. And then you have some relapse that you have to take it into consideration, about 27%, so almost 30%. So this is an important relapse. Other researchers published about those plates in the American Journal of Orthodontics. They found that you can use them to close severe anterior open bites by intruding the posterior teeth. And I show you exactly the mechanism, how they work. And when you intrude, for example, the upper teeth, you have to make sure that the lower teeth, they are not extruding. So you have to find ways to keep the lower teeth in their initial position, or also try to intrude those as well. Many other papers also by Talents, who was one of my colleagues and professors at the University of Rochester in Eastman Dental Center. They found that after intruding posterior teeth, you have to take into consideration that you have some eruption or extrusion of the mandibular molars. This is what I told you before, okay? But you can intrude up to 2.5 or 3 millimeters, which is a lot, because intruding 3 millimeters posteriorly, that means you can close a lot of open bite anteriorly. And adolescent patients tend to demonstrate more favorable effects of mandibular autorotation than do adults. And I do have a good sample of adult patients that I was able to intrude posterior teeth and have the mandible to auto-rotate and close the bite. One of those patients I will show you today. Now, the question when we use those plates, is it all good? It's not all good because we also need surgical intervention on those cases, which is more invasive than just placing a mini screw. We use an oral surgeon to use them, so there's an extra cost involved on those that you have to take it into consideration. Now, this is Penelope. She's a class 1 with severe open bite. She came to our practice. She said that I know what my problem is. She's been to almost every orthodontist in Cyprus. I don't want surgery, so if you can treat me without surgery, please let me know. So we examined her face. She's a long face with maxillary retrusion. Also, she was mandibular protrusion. Long nose as well. So that's how she was presented to us. She had occlusion just on the second and third molars. Now, ideally, when you have open bites like this, you have to ask your patients to remove the third molars in order to help you close the bite, because then by just intruding second molars, your life is easier. But she didn't even want to extract the third molars. So that made our life much, much more difficult. But we said, okay, let's try and see how it's going to work. We know Invisalign, it's very good for expansion. We've showed you that. However, when you have such a big open bite, you have to use some screws or plates in order to be able to intrude posterior teeth. And this is what we did. We used the plates posteriorly to help the intrusion. Here, this clean check doesn't show anything. It's just showing that intrusion posterior teeth, you can actually be able to close the bite. But on real life, never expect that things are going to work like this, because in order to be able to intrude posterior teeth, you have to hold on to something. You have to have the plates or the mini implants, something that is going to help you as anchorage to intrude. The expansion, it's something that we know it's easy to get. So here, we did intrude posteriorly. That's how we're able to close. We had a little bit of open bite still on the bicuspid areas, but we worked more on that. You see how nicely the shape of the arches changed. But here we had 2 mini screws on the palate, and we used the Sugawara plates on the outside, as you can see here. So we had the plates. You can see the plates running down. See how nicely now the bite is closing. And in addition to our Invisalign, that we ordered a lot of intrusion posteriorly and extrusion of the anterior teeth, we're able to support the intrusion with elastics by having the plates on the outside, on the buccal areas, and running elastic to the mini implants on the palate. So this is the panoramic of our patient. And see on the lateral ceph how nicely now the mandible auto-rotates after intrusion of the posterior teeth, and we were able to close the bite. This is nice. The question whether Invisalign is for complex cases or for the easy cases, Invisalign is for every case. So we use Invisalign for every case, even for those surgical cases that are sometimes seem to be more difficult. So here is during the process of closing, and then we did some composite buildup on the anterior teeth, and we finalized those composites later on. This is our patient at the end of treatment. Here she has a little bit of an open bite on the second bicuspid and the first molar, but I think here it's very easy to change maybe a little bit the porcelain and even make it more to close or run some elastics to close it even more. And the left side with the bite, which looks actually very good. The change on the shape of the arch, the new retainers in place, the composites on the upper arch, and the lower arch with a different shape. And this is our patient. So Invisalign is definitely for the easy and also for the complex cases. There's no question about that. So the way we intrude posteriorly is that we have the plates and we intrude mainly the 6s and the 7s. We get them out of contact with the lower arch. And what happens is that the mandible auto-rotates. So this is what happens. This is very basic mechanism. I would definitely recommend to remove wisdom teeth when you do this kind of movements. Those are difficult cases. And I would always recommend, if you have the tongue involved on those open bite cases, to get a consultation with a speech pathologist that they work with tongue thrusting. So it's for the easy and for the complex cases. Now, let's move to a little bit more advanced cases, I would say, or cases that need a little bit more thinking. This is Constantine. Constantine was already treated twice before, and she came to see us with a huge open bite. He said that he didn't like his smile. He had a long face with maxillary and mandibular protrusion with a frontal open bite. The oral hygiene was horrible. Of the upper. So in a case like this, that he's touching only on the molars almost on both sides. And after 2 previous orthodontic treatments, I didn't think that I could treat this case by using the plates because he already had treatment and I want to make sure that I would be more drastic on closing his bite. So we removed the retainers. He had a good oral hygiene and we started working on him. He would go to London to study, so we had about a year to work on this case. So here, Invisalign is making some movements that I don't like, so you have to be careful. You see here, it's actually extruding a lot the anterior teeth. So in a case like this, that he's going to have surgery, you don't want the company to make a lot of extrusion on your teeth. You just want them to level, and then you decide with your surgeon how you're going to end up closing the bite. So for him, we did just the leveling and aligning for 4 months. He went into surgery. We send our patients with some ceramic brackets for surgery. This is the way we like to do it, as you can see here. We take an impression and send it to our lab. So he makes a wire that fits into the bracket slots that we placed on our patient 2 days before surgery. And then he comes back after the surgery. The bite is closed. We do have some work to do on the right, but everything definitely looks much better. Nice exposure of my upper incisors. And we're able to finalize the bite. He had small laterals. Maybe here we can build up a little bit. He would leave. He didn't want to do anything more on his teeth. He was very happy. So the arches changed very nicely. And I was able to close his bite with surgery on the upper and the lower jaw and also genioplasty. The lines that I discussed with you, a perpendicular line that is coming down from ANS, and also a line from Pogonion to the lower incisors. Those are lines that are very important when you trim and plan your cases. And those are the lines that I learned from my friend Renato Bocconi and Mirko Raffaini that they're using on their surgical cases. So this is Constantin with a new face, the new occlusion, and the new smile. We're able to close everything. Changed slightly, but it was much better after. The oral hygiene, still you can see accumulation of plaque behind the incisors. And this is our patient at the end of treatment. So let's discuss again a little bit about the lines that I told you before. First, the upper lip support. This is a line that is drawn perpendicular from A and S that we want to be tangent with the upper incisors. And the line from Pogonion that we want the lower incisors to be tangent to this line. And something that is also important when you do orthodontic surgery is the cant of the occlusal plane. The one that Utse and Lawrence are talking a lot on their presentations, and they also have a publication about the importance of the occlusal plane when we do orthodontic surgery. So talking about the upper lip support, the line that Renato is introducing, this is the ideal. This is when we have upper incisors in front of this line. And this is when the upper incisors are behind the line. So if the upper incisors are in front of this line, then we may consider extractions, we may consider IPR, and when the incisors are behind, we may consider opening spaces and have some veneers, build-ups, or do things in order to bring the upper dentition more forward. So this is the ideal when the upper incisors are in this line. This is the excessive upper lip support when the upper incisors are more forward. Again, here extractions or IPR. And this is when incisors are behind. You see how the lip here is deficient. That's why it's called deficient upper lip support. So pay attention on those lines. Easy to draw and easy to identify problems for your patients. So for the lower, this is the ideal. This is the defective chin definition, so the chin is behind. And in a case like this, we may decide to do an advancement genioplasty. And this is the excessive chin definition. You see how the lower incisors are behind the chin. So in a case like this, again, we may decide to do genioplasty. Reduction genioplasty would be the best. So the ideal chin definition, the deficient chin definition, and this is the excessive chin definition. So those lines came to us, finished orthodontic treatment. You see that there's nothing from what we've been discussing for the last hour and a half. So the incisors are totally proclined, the chin is so far behind. So upper lip support and lower chin definition by Renato Bocconi, and the cant of the occlusal plane that is so important for our patients when we use them with orthodontic surgery. Now, I have two more cases to share with you. This is Elena. It's a patient with class 2 division 1, mandibular retrognathis. She came to us because she didn't like her smile. So we presented to her all the options, but the best option for her, of course, would be to have orthodontic surgery. We never thought that we would be able to treat her without surgery. She had very narrow arches on the upper, spacing and small laterals. So this is a multidisciplinary case, a case that needed prosthetic work. She needed also orthodontic surgery and orthodontics. So in the preparation here, the ClinCheck is a great tool to show us how the arches are fitting after the surgery. So here it's a very easy case. You just level a line, leave some space for the buildups of the laterals, and then let the surgeon do the work. We also see here that we have impaction of the molars that we have to pay attention when we do orthodontic surgery. We have to remove those molars at least 6 months before the surgery. And we have to pay attention to the asymmetry. You see that the left side is different than the right side. So just easy preparation, develop the arches, and make very good coordination. We place the braces, as we discussed, ceramic braces 2 days before surgery. We place the arches also with hooks on that were bended to us by our technician. So the patient goes to the surgery, as you see here. Then she comes back. We work a little bit about a month with some elastics on those braces, and then we remove the braces, go back to Invisalign in order to be able to finalize our case. So this is what we did here. You see everything is going into a class 1. Just we prepare with Invisalign. We expanded the arches, but we do have a very nice smile of our patient. Excellent 3/4 views. Nice some of the lateral and a little bit of build-up on that. Our occlusion was excellent. The smile and the facial aesthetics also good. That we do pay a lot of attention. The exposure of the upper incisors, it's very important when we do orthodontic surgery, also when we treat easy. Can you see my screen well? Is everything okay? And also, can you hear my voice well?
Yes, right now it's okay. It was the problem with the connection a minute ago, but right now it's okay.
All right, very good. So here you can see the shape of the smile that changed. The profile, definitely much better. So this is a case that benefited from the multidisciplinary approach. We as orthodontics are very important to decide what and of course communicate with the patient in order to be able to finalize the cases into a conclusion. And see in the shape of the arch, that had tremendous difference. The exposure of the upper incisors, excellent coordination and smile aesthetics. And we had very good aesthetics, and our patients are always happy to smile for us, as you can see here. So sometimes it's better to just remain silent and smile. So this is what we do as orthodontists, and this is what makes our patients happy. And this is the last patient that I would like to share with you. This is Joanna. Joanna is an excellent person that came to us because she knew exactly what she wanted. She was a class 3. She was a professional dancer, very successful. And she came and said, well, I don't spend too much time in Cyprus, so I know I would like to get Invisalign, and I also want to have surgery for my jaws. So those are the kind of patients that you want to run into your practice every day. She also had previous orthodontic treatment, but she knew what she wanted. So that was the best. Long face, maxillary retrusion, smile, gummy smile, concave profile, prominent nose. You can see the signs of the previous orthodontics. We clean the teeth. We try to give her better oral hygiene. So we just did a little bit of preparation with Invisalign, the same procedures, coordinate the arches. Something very interesting on this case, we decided with the surgeon that we wanted to remove the second bicuspids. And the best time to do that was during the surgery. And that would give us better coordination and aesthetics of the upper and the lower arches, and also the aesthetics of the smile. We prepared that with a clean check, so everything was ready. She went into the OR with the same ceramic brackets like all of our patients go. And this is what we planned for her. Extraction of the second bicuspids, and an excellent tool that we have to check whether the coordination of our upper and lower arches is adequate. You see here, patient and the conventional attachments. This is right after orthodontic surgery. Because we had the extractions, we had a little bit more overjet anteriorly. We keep the wires and the brackets for about 6 weeks. Then we remove them and go into the Invisalign again. The patient is looking better now. The swollen is going away. And this is our patient looking much better a few months later. The profile, the nose, she also had work on the nose, surgery on the nose during the orthodontic surgery. This is something that we do quite often, even though it's not recommended by some friends of us. However, we like to have all those surgeries at once so the patients can finish and be happy at the same time. And when you have excellent cooperation, the surgeon, maxillofacial with plastic surgeons, I think we can have very good results. So here, according to the plans, we're closing the spaces and coordinating the arches. And this is our patient. See the tremendous change on the profile and the smile, that she's really, really happy. The face has changed completely. Now the spaces are looking much better here. We're expanding a little bit the posterior segments. And many times you need the help of elastics in order to be able to do that. The gummy smile posteriorly looks much better. This is our patient. So the before and after. The before and after here. The 3/4 views that give us a very good indication of the line from the zygomatic bone on the cheek down to the chin. This is what we call the S line, and it looks fantastic on here. Especially you can see this line here. This is what we want to have on our patient, this S line. It's very important. The change of the nose here, you can see the change of the chin, the anterior aesthetics, how the lips are now so much better now. The occlusion on both sides. So we're missing second bicuspids. We extracted them during surgery. And before and after x-rays. And this is our patient after treatment. So, and maxillofacial surgery. We create smiles that are fantastic. We change lives, but in order to be able to do that, we need very good planning. We need to use our knowledge and expertise, plan our patients, spend time with the clean check, because if you fail to plan, you plan to fail. And I love to see her smile. She's so beautiful and excellent, excellent results. So another advice that I would like to give you is to try to find the best surgeons to work with. So when we treat patients with a multidisciplinary approach, or any patients, we have to listen to their concerns. We have to focus on occlusion and the face. We have to plan our treatment and present all options. Do not afraid to tell them that they need extractions. Do not afraid to tell them that they need orthodontic surgery. And do not harm the face. I showed you cases that the face was harmed because the orthodontist was afraid to tell the patients that they needed orthodontic surgery. Where is the limit? I don't think that there's a limit by working with Invisalign. And are there any complex cases? I don't think there are complex cases. I just think that there are cases that they need better planning. And I want to show you a video of Joanna and how happy she is with her new smile. So I think it's very important to stand out. Make sure that the key component of your strategy forces you to stand out. I do believe that Invisalign, it's a system that really made my practice to stand out. It gave me different ways to treat my patients, easier ways to treat my patients, more comfortable for them. Some of my patients wouldn't get in any braces if we didn't have this technique. So try to use it. It's a technique that you can use not only for just easy cases, but you can use them for the difficult cases. I'm very happy that I was introduced to this technique. And I want you to remember the word essence, which is so important when we treat our patients with Invisalign. Less emergencies, shorter appointments, safety, eat what you want, no plug, no pain. It's more comfortable, and of course, it's aesthetic. I would like to finish with a saying of Socrates that the only true vision is in knowing you know nothing. So for me, the way I'm getting out to my professional career is always I feel that there are ways to explore and new things to learn. So I'm always saying that I know nothing, like Socrates was saying. And I would really like to thank you for spending time with us tonight. This is my email, and if any of you would like to send me an email or any questions based on my presentation, I would love to answer. And I would also like to invite you to come to Cyprus for the European Orthodontic Society meeting. It starts the 30th of May. So, are there any questions? Okay, yes, we can wait if there are some questions that come up. That would be nice.
There was a question How you transition from the braces after the orthodontic surgery to the Invisalign aligners? You do the new scanning, or you have the ready prepared aligners for that?
Yeah, I try to have ready prepared aligners, but it doesn't work because you may have some small movements during this period of the surgery. So I make a new scanning most of the times now. So new scanning.
Another question that was sent: do you use the method then when you perform the restoration of the teeth before the orthodontic treatment, just to ease up the final position of the teeth and not to guess how they would look like?
The majority of the time I do it in between, so close to the end or somewhere in the middle of treatment. I just remove the braces, or if I use Invisalign, just before a new scanning. I like to build my laterals to make them look nice, because at the end I want them to have the right shape and position in order for the patients to look better. And it's easier for us to understand if we're in very good shape of aesthetics and also of the function of the incisors. So most of the times I do it in between, but sometimes I may do it in the beginning, but in between.
What about the cases with severe attrition, the worn out teeth? You would restore them after the orthodontic treatment or before the orthodontic treatment?
Again, I do a lot of in the mid treatment, somewhere in the middle of treatment. I have cases that I have done it after, but yeah, I like to do it in between, in the middle of treatment. So between scanning, between additional aligners, I like to build up the teeth that are worn out. The reason I don't do it on the beginning is that many times you have a lot of rotations, you have a lot of crowding, so it's not easy to restore them nicely. Okay, I guess.
There was another question. Do you perform the expansion, the skeletal expansion with mini screws like MARPE on adult patients?
I don't use it that much. I've seen that it's quite common in Russia now. I get a lot of patients from Russia that they do use a lot of those screws and the expansion appliances for adults. I'm not a big fan of that. I like to keep things simple, and I'm always asking myself, what would you do if the patient was your child? So I wouldn't like those screws to be placed on myself, because I do a lot of expansion, and I showed that you can do a lot of expansion just with the aligners or with the traditional braces.
Well, it seems there are no more questions, so thank you very much for your lecture.
Okay, thank you. Thank you. It was a great pleasure to be with you. And yeah, I'm looking forward to meet you again. Okay, bye-bye. Have a good night. Bye.